Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello, Rhonda. Welcome back to the United States.
Thank you.
Your fantastic and exhausting month abroad and your first grandmotherly duties.
Yeah.
And congratulations on
Thank
the
you so much.
twin grandchildren.
Thank you. Thank you so much. Yes, I had a really incredible month helping my son and daughter-in-law take care of their newborn twins. And it's great to be back, and it's great to welcome all of our listeners in the United States and throughout the world to this is the Feeling Good podcast, episode 353. And this is going to be another example of the brilliant personal work that you and Jill did in the Tuesday group with one of the most beloved and colleagues that we have in the team community. And so shall we dive in, or David, do you want to set some context?
Well, yes, we'll dive right in, but can we call you Dr. Lee?
Sure.
You know who Dr. Lee was in Palo Alto?
I do not.
He was, I believe, I think that's the name of the man who started the Palo Alto Medical Foundation, the clinic that's associated with Stanford. It just occurred to me. I remember that from when I was a medical student. And I'm sure no one in the podcast would be interested in what I just said. So we're off to a great start already. But we do have a wonderful podcast with a wonderful colleague, and it's on a topic that I think a lot of people can identify with. And there's an interesting twist to it as well. But one of the techniques I've created, feared fantasy techniques, is called no practice. A lot of us have trouble saying no, and I'm a member of that group, and I get people asking me for things, almost on a daily basis, and I probably say yes to more than I should, but I just get so excited by what people are saying, and I want to write them a good email back, but it can eat up a lot of time, and sometimes we have to learn how to say no in order to not get overly overwhelmed with everyone's requests. And so what we learned in this podcast, which you'll watch out for, it's maybe not as simple as it seems, because when you do no practice, and you'll hear us doing this, you just have one person making demands on you. You just practice saying no, and there's certain principles to keep in mind, to do it in a friendly way, and but to be firm, and don't spend a lot of time on it. Don't give multiple excuses. And there's that would be called behavior therapy, to just, here's behaviorally what you're supposed to do, and let's practice it so you can do it. But what emerged, which you'll find fascinating, is that here we have a brilliant and really kindly and wonderful person who we'll call Dr. Lee. And suddenly we get a curveball when we try to do our no practice, and we'll explain at the end, what happened and what it all means, because it will bring us back to something that we've often mentioned on this dialogue, is the importance of your inner dialogue. What you say to yourself can have a huge impact on your outer dialogue when you're trying to learn a new way to communicate. So shall we let her rip at this point?
Let's let her rip. And
Okay.
then Dr. Lee will join us at the end of the podcast at the conclusion to talk about how this experience has impacted him.
Yeah, fantastic. Yay. So, Lee, on the depression test, you scored a 12. This is just a T equals testing to get us started. And that's about a little more than halfway from 0 to 20. So that's kind of good, strong, moderate depression. No suicidal thoughts or urges. The anxiety is 13 out of 20. So similar to the depression, it's in that strong, mild range, maybe heading to into the severe range, the bottom part of the severe range. The anger scale is 9, a little under halfway, but it indicates a lot of anger and frustration. And when you hear about the situation, I think you'll all understand why Lee is feeling kind of frustrated and dispirited too. And then the happiness score is 8 out of 20. And you're not feeling a lot of happiness or joy or self-esteem or productivity or pleasure in life and at all. Some of these are moderate and some are somewhat, but nothing's a lot and nothing is extremely. And so there's a lot of room for improvement in positive feelings. And let's see if Jill is with us yet.
I am here.
Oh, fantastic. Hi, Jill. It's great to see you. I just went through his testing, which you've probably already looked at. So why don't we dive into the E equals empathy phase? And you can start us off if you like, Jill, or we can just ask you, Lee, to tell us a little about. Everyone has the daily mood log, can read it, and you're superbly trained and brilliant and ethical psychiatrist with fantastic knowledge of psychopharmacology, but now years of team psychotherapy training under your belt. So you bring an awful lot to the table and feeling some pretty darn intense negative feelings and, virtually, 2, 4, 9 different kinds of negative emotions, all pretty moderate to severe to extremely high, anxiety being the highest, but guilt of 85, anxiety 90. So, feeling of inadequacy, 90%. And I had just emailed you that I think one of the reasons that I kind of left full-time institutional psychiatry was kind of, I sensed the same thing.
Yeah, you've got a lot of that correct. One of the really knotty parts of this is that I often get into interactions where, in order to do what I think is right and ethical, I have to say no to someone's face. And then I feel really bad doing that. So there's an interaction where I have to account for what's good for the patient, what's good for me. And then this third thing, which is how do I conduct this interaction, I suppose on some level, to make it appear that I'm having a proper interaction. And I feel a lot of strong emotions related to whether I'm doing that well. And then I feel critical that I care about that so much. Could I give a more concrete example? Because I think that may be...
Yeah, I was going to actually ask, I feel like I don't actually understand what's happening because I guess David gave an overview, but it would be much more helpful to me to really hear you, Lee, tell us from the beginning, because I feel like David maybe knows or understands stuff that we don't all know. So I would love you to actually start fresh, assume we don't know anything, and just tell us your story, tell us what you've been experiencing, give us some details, kind of bring us all into your story so we can connect with you and understand, how things have been for you. That would help me a lot.
Sure. Thank you. I've been working at a hospital with mostly a population of people with treatment-resistant psychosis, people who are there for very long stays, very difficult to treat, and many of them are there on an involuntary basis. And in this hospital, And even when I think I know what's right to do in some of these situations, I feel a lot of negative feelings related to actually having my way with situations, saying no to patients who want to discharge, saying no to patients who want benzodiazepines or other drugs that may not be particularly good for them. And so I feel like I'm in a can't-win situation where I feel like I'm bad if I don't have the conversation in one way and bad if I do have the conversation in another way.
Bad if I do and bad if I don't.
Yes.
Could you give us an example of this kind of a conversation?
So not specifically rooted in this situation, one of the ways this frequently comes up is with discussions around benzodiazepines, which are addictive medications used for anxiety that often lose their effectiveness long term.
Like benzos.
Sorry?
Like benzodiazepines?
Yes.
Yeah, Xanax and stuff.
Like Xanax. Yep. I've often had patients ask me for these, and then when I explain why I don't think it's the correct thing for them, I may end up in very protracted conversations about it and end up feeling guilty in proportion to how hard they press the issue rather than in proportion to whether I believe it's the right thing or not.
And that's part of what's troubling you is like, not only are you feeling bad during these conversations, right? Because you have your beliefs, right? In this case, for example, that it's not safe or advisable to prescribe this patient benzos or continue benzos, and the patient is pushing for it. You feel bad because you're having this long, protracted conversation that at some level you don't want to be probably wasting your time on. And then you also like feel bad about the fact that you're feeling bad because you're telling yourself that you shouldn't care about like this kind of a thing, right? Like almost like you're mad at yourself for caring so much about your patient that you get bothered by it. Am I understanding you correctly?
You've got that correct, yes.
Yeah, so it's that you're feeling bad, and you're also telling yourself that you shouldn't feel bad about it. And you said that earlier too, almost like I feel bad that I actually care about saying no. I want to be able to say no to people and like not care that they don't like me and not care that they're mad at me and not care about all this kind of hostility and friction. You'd like to feel like I'm doing the right thing, and so it doesn't matter that people don't like me for it.
Yes, and on some level, I think I have a certain degree of fear that those feelings may indicate that I might actually be inappropriately persuadable.
Mm-hmm.
Thinking that you should be tougher.
Right.
Yeah, I think I should be tougher and that I should be softer.
Yeah.
Right.
So, and in this most recent hospital I've been in, these sorts of dynamics have come up frequently with patients, both about what they want to be prescribed and when they want to be discharged. Sometimes their discharge issues are related to things beyond my control, and often they want to be discharged and just don't have any insight into how dangerous it would be for them to leave the hospital and don't have a reality-based ability to even understand what it is that I think and what I've said to them. So I may, in some cases, end up in looped conversations, having the same conversation with the same patient multiple times because they can't absorb what I'm telling them. And I don't feel good just cutting them off without a conversation at the next time they want to try to understand.
Yeah. Can I see if I'm understanding you correctly so far? And then maybe we can also like hear some more from you, or is there more you want to say at the start here, Lee?
There's just so much, and I'm afraid of taking up the whole time with it and maybe still not covering things appropriately. But if you where you've got your curiosity, let's lead there.
Well, I can see if I can summarize what you've said so far, and then I think I'd love to hear more about all of what's going on. And I'm not so worried about you taking up all the time, and more want to really try and understand, because it sounds like you've been struggling a lot, and there are a lot of different factors. So maybe you can clarify that, like where you're at with that. But essentially, what you shared with us is just that it has been sounds kind of like an angst-ridden experience working at this hospital, where the patients you're working with treatment-resistant psychosis, which really sounds incredibly challenging, actually. That the majority of these patients then are involuntarily hospitalized, which is also a uniquely challenging population. And that you feel like you're often sort of at odds with your patients about what they want, which is maybe to get discharged or to get their benzos or to get something. And what you know is medically indicated, which might mean to keep them longer or to refuse giving them certain meds or to give them other meds. And so you're often at odds with your patients, which sounds incredibly challenging to me and stressful. And that you oftentimes feel like your patients are essentially pushing you to do things that you're not comfortable with. So you have to have these extended conversations with your patients, which are very, frustrating and unpleasant, and they feel like they last for a long time, and sometimes they're repetitive because your patients aren't actually even digesting the information that you're giving them. And so you have to spend all this time kind of looping back, and you're trying to be empathic with your patients, but then end up feeling, you said, kind of beaten up from these extended conversations. And then you're upset with yourself for feeling beaten up, almost like you're supposed to be able to, you're like, put on your bulletproof vest and go to work, and Teflon shield, it's all supposed to just kind of roll off of you. And it bothers you that you're bothered by it, that it feels upsetting to you that you're telling yourself, I should be stronger, I shouldn't be so bothered by this. But then you're also telling yourself that you should be more empathic. And so you're feeling a little bit like, damned if I do and damned if I don't.
And another aspect of these difficult patient interactions I haven't mentioned thus far is that some of these patients are very psychotic and also I think may be actually trying to press my buttons or not telling the truth about what they know versus what they don't know. And so I have this model uncertainty about whether I'm in an interaction where they don't know what's happening versus one where they're actually trying to hurt me. And I don't know whether to, quote unquote, whether I'm permitted to be angry with them.
Right. Well, because it's almost like there are times where you don't know whether someone is truly psychotic or doesn't know or understand what you're saying, or whether they're being kind of manipulative. Is that right? When you say like pretending not to know, or is that what you mean?
Right. So in some of these interactions, I don't know if I'm being helpful to them to the greatest degree I can, or whether I'm just playing into something where they're not missing any information or not understanding me at all. Their objective is just to drag it out of me.
Gosh, yeah. Right. And so you had some thoughts on your daily mood log.
Yes.
Yeah. And how do you, so far, and just in terms of my understanding of what you've been experiencing, and I guess maybe I didn't use enough emotion words, so I'll put a few in here, but I definitely understand that you're feeling guilty and bad and ashamed. And then
anxious.
Yeah, and anxious and worried, and some I see on here, and you describe some feelings of incompetence and self-consciousness. But then there are some of these emotions like frustrated and stuck and defeated, angry, annoyed, irritated, from being in these challenging interactions and from sometimes feeling manipulated or wondering if you've been manipulated. So I guess I'll stop and say, how am I doing in terms of understanding you? And then what else would you like us to know so we can, think about how to help you?
And just to add, hopeless and discouraged too.
Yes. I think you've gotten everything that I've said thus far.
I just want to say, Lee, that I feel so sad hearing you share this, like honestly. And I know there's this whole part about you almost being hard on yourself for having all these feelings, but I have so many feelings hearing this story. Like, it's just, I don't know what the words are, just so yucky, right? And I just feel like you're kind of on a tightrope, on a high, I don't know what the word is. And it's so clearly how much you care about your patients and about doing the right thing for them. And so I appreciate just how much you care about your profession and about your patients and about really doing the right thing.
Your professionalism and your humanity, both.
Thank you.
Yeah.
Yeah, that is true. And one other aspect to my feelings around this is also that I had a lot of cases where I was pretty limited in what I could do for the patients. And I ended up feeling like I was, in some cases, keeping people in the hospital involuntarily just because I couldn't think of anything else to do for them. They wouldn't be well enough to leave, but I didn't really have a path forward for them either.
Mm-hmm.
And did that give you a feeling of helplessness or shame or guilt or inadequacy?
All of those, yeah.
Yeah, and pretty intense too.
Yeah.
Sounds like awful existence to be in a situation like that and thinking like that.
It was.
How are you feeling just at this moment?
Feeling a little, I don't have a name for the emotion. I'm feeling a tingling sense in my lower head and upper chest.
You feeling sad?
I think I may be sad. I often find it difficult to put the words to how I'm feeling in a particular moment and have to draw inferences from patterns of thoughts. I know some people actually feel feelings and like have this somewhat more direct knowledge of their emotions than I often feel.
What are the thoughts that are going through your mind right now as you're feeling that tingling and feelings in your chest? What are you thinking about right now?
I'm appreciating you holding space for me here and appreciating especially the sense of sadness that you expressed, Jill, which was relieving for me to, it's like you expressed something for me that would be harder for me to have an experience of by myself.
Yeah.
I was wondering too a moment ago if you were feeling tearful, but I can imagine that it might be difficult to access that too.
That is difficult to access.
But you have such a big heart. I wouldn't be surprised if you feel so sad about these people you care so much about.
I do feel that.
Yeah. Let me ask you how primarily Jill, but a little bit David as well, have been doing understanding, on three counts, understanding how you're thinking, what you're experiencing, how you've been feeling. Now, that is number two, and not number three, if to what extent you're feeling sense of acceptance.
You're doing well. I think you're in the A range, both of you, and I feel accepted right now.
Oh, that's great. I'm really happy to hear that, because I think the world of you, and it just seems like you've been pouring your heart and brilliant knowledge into a meat grinder kind of situation. And I'd love to see you in a happy situation with people who admire you and respect you and want to follow your leadership. And I don't know what that would be, but that would be so neat to see that. Let me ask you a question, Jill. Would we want to move into a little bit of the A range in terms of the assessment of resistance, and see what Lee's goals are tonight? Because I can see a lot of really great work that we could be doing tonight. But to tell us, Lee, would you be ready to roll up your sleeves and take some piece of this? Because there's a lot of different kinds of pieces, and we have some wonderful tools, but we don't want to cut you off before you're ready. And if you need to talk some more, that's really good too.
I think I'm ready right now, although when I get to the daily mood log and saying some of the negative thoughts, I may want to expand a bit on their background. But I think if we can have some flexibility.
Sure, absolutely. Let's do that. You want to try that right now a little bit?
Sure. Is this the invitation or the miracle cure point?
This is just doing a little bit more empathy, letting you expand a bit more on some of your negative thoughts, like what you were saying.
I'll go to the daily mood log.
Yeah.
Oh, wait, can we ask Lee before you do that? So David did an invitation, and it sounded like you said, yes, I'm ready to get to work. I'm just wondering, so that is the moment in time, but do you have a sense of if a miracle were to occur this evening and you were to get just what you wanted out of this session, and you walked out of here, with just the outcome that you wanted, what it is you're looking for help with? What would change? How would you feel differently?
What I'd like to change is I'd like to stop having a pattern of interactions where I spend a lot of time explaining something or saying no at length to someone and feeling bad about it afterward.
You are saying you'd like to stop having interactions with people where you say no, where you have to say no at length, and
where I have where I'm explaining myself at length for why I'm not giving someone something they want, and then I feel bad for setting that limit.
I have just a quick long shot question for you here. It's probably a waste of time, but the statement you just made is so classic. And when I started my practice, a patient told me, "Oh, there's this great book called When I Say No, I Feel Guilty." And so I went and read it, and I loved it. And I got my wife to read it, my son to read it. And we all, it was kind of a simple book, but it was really helpful. It was by Manuel J. Smith. Have you ever heard of that book?
I have not.
Oh, well, you might kind of have fun with it. Just a little supplement with what we're going to do tonight, because, I think it's hard for a lot of us, but you're really deep enmeshed into the thing of, because you love people and want warmth and trust. It's really hard for you to say no, and then when you do, and so you're slow to make that happen. And then when you say no, you feel real bad about it afterwards, and that I think that's a problem that probably almost everyone in our group tonight can identify with it. I struggle with it, quite a bit too, and I know Jill does too.
Yeah,
I have a hard time taking in the positivity of that interpretation, because I think that sometimes the person needs to hear a no.
Right.
And then the struggle for me in telling them no seems selfish to me.
Yeah. So it seems selfish to you to say no. And well, I can identify with that too.
Selfish to me to be upset that I'm saying no, because the no is in their best interest.
Yeah, that's inappropriate because you're doing something to help them in their best interest. And so you shouldn't be feeling guilty.
Yeah.
Yeah. And then you beat up on yourself for feeling guilty and upset.
And I also feel weak that I'm allowing myself to be dragged into this, where it feels a bit like theater at times, because I'm working on this uncertainty about what's actually in the other person's mind, whether they actually don't understand or need some help understanding what's going on, or whether they're actually just trying to create pain and inconvenience.
You don't know if you can trust them and what their really motive or goal is.
Yeah.
Yeah.
Sometimes.
And
there's something I'm not sure I totally get yet. Can I just ask a little more? So we know that we can't change other people, right? So when you say I'd like to stop having interactions where I say no at length to people, right? Where I have to keep explaining myself. So let's just assume the world isn't going to change. So people are going to still not know, not agree, right? Like that part we can't change. So
they're still going to want their benzos.
You're right. So they're going to still want their benzos, and they're still going to disagree with you, and they're still going to say, no, I want this thing. And so that part isn't going to change. So I'm confused. I'm genuinely confused about, do you want to be able to say no and have a shorter conversation with them? Like say no, feel confident in saying no, not really care that they don't like the answer, and then move along? Is that your goal?
I want to not feel bad afterwards is the primary thing. And okay. I suspect that the way I get there probably goes through having a shorter conversation, but I'm not sure of that.
Mm-hmm. And then you want to not feel guilty after? Because the guilt, okay. So not feel guilty after, because you might feel bad that you just spent an hour of your time talking to someone, but that's like an annoying, those are very different emotions. Like guilty is like, I should be doing this differently. Bad that I just had this hour-long conversation is probably anger and irritation and annoyance, right? That I just wasted all this time, which that would only be fixed by spending less time on the conversation, I think.
Yeah, I think that it would probably be ideal for me to actually spend less time on the conversation and not feel bad that I didn't give them that conversation.
Right. So it is a lot about sort of like trusting my side of the story, like having a reasonable short bout of empathy to express my feelings and listen to the other person, and then feel confident enough to kind of cut it off, move on, and not feel guilty.
Yeah.
But you get trapped in these long conversations with a lot of drama.
Yeah, it's like being drawn into an empathy loop where the empathy isn't taking, but it feels like I'd be a jerk to stop.
Yeah.
Exactly.
So that's another negative thought. I'd be a jerk to stop.
Yeah.
So it seems like David and Lee, maybe we can think about this. And David, maybe there are other conceptualizations. I'm trying to wrap my head around our different options, but one obviously would be, thought like we could work with Lee on a daily mood log that really spells out these thoughts, like I shouldn't say no, and I should talk to the patient as long as they want me to, and should put the patient's needs first or something, these kinds of guilty thoughts and thoughts that prolong the conversation. There is potentially a different direction, which would be more like actual communication practice, right? Like 5 secrets practice, but then like wrapping it up and moving along in some way. Like most primary care doctors only have, 15 minutes. And so even if you ask more questions, they ultimately say, they find some way to wrap it up and get you out of their office. There's some sort of an external, I guess there's the internal solution, Lee not feeling guilty anymore and feeling more confident. And then there's the external solution, which is Lee figuring out how to end these conversations, more.
And also more at peace with myself when I do screw up and get involved in a long dramatic conversation.
Right. That's right. That's 3. That's the third one, right?
Yeah.
Yeah, right. Accepting that, I did just do that. And then maybe even be able to feel good about it rather than bad about it, right? Because it shows some good things about him, right? Mm-hmm.
It would be nice to have a positive reframe on doing that when I do it.
Oh, that's easy right there.
Yeah.
But here's three directions we could be going in, and we can't do everything simultaneously. But if we do one thing and get it right, it sometimes opens up the doors to easier solutions to the other pieces as well. Does any of this make sense to you in terms of what we might focus on together?
That I feel bad.
Yeah. Right. Okay. Number 1, feel bad about feeling bad. I feel worse about my clinical decisions when patients protest. It's a sign of my inability to align my emotions with my own understanding of reality. And I take it that in my clinical decisions, I kind of get upset, even though I know what's realistically the correct decision for the good of the patient.
Yeah, I get upset with the patient's upsetness, and I feel like I'm failing the patient and that I'm being inadequate, not because I'm actually making a decision that's incorrect, but just because the patient thinks I am.
Yeah,
and then
right.
I feel weak and irrational, or
irrational guilt.
What the patient thinks is true.
Yeah.
But isn't that really the thought then, is I shouldn't care what my patients think?
There's something to that, although go ahead. It would never show up with quite that wording, but I shouldn't feel as though my patient's feelings are accurate.
I shouldn't get sucked in by my patients.
Say again, David?
I shouldn't get sucked in by my patients into these long discussions.
That's more like it, yeah.
Yeah.
Yeah, I shouldn't get sucked in by my patients.
I'm helpless because it's wrong to ignore them and avoid them or argue, and I can't engage without them.
Without doing one of those things.
Without ignoring them, avoiding them, or arguing.
Yeah, it seems that way sometimes, that I have this small set of choices and none of them feel good. And I'm looking for another way so that, I can not feel bad about those things that seem off limits now.
Yeah. And let me ask you...
Now that we've done that, it's actually less obvious to me than I thought it was that working on these thoughts will help me with the skills of saying no.
You hadn't thought about that? Or you had?
Having reviewed these thoughts right now, it's less obvious to me than I thought it was that this would be a productive direction to go in terms of my actual skill at saying no and feeling it well.
Yeah. So if I understand what you just said, because I got confused, but you're thinking it could be useful to get a little skill at saying no, a little no practice.
Yes.
Yeah, absolutely. Yeah, that's right.
What I would say is there's goal, we talked about goal 1 would be to not feel guilty, like to be able to say no and not feel guilty about it, right? And if you could say no and not feel guilty about it, in those situations, you wouldn't have these thoughts, because these thoughts are saying, like, I'm weak-minded for caring. I'm weak-minded for staying in these interactions, right? These three thoughts are that other layer, right? You have the I feel guilty, and then you have the I shouldn't feel guilty. And these thoughts, I think, are all about the I shouldn't feel guilty thoughts.
Right. The best way I could see this helping me is maybe getting those second layer thoughts might help me do positive reframes on the first layer thought.
Yeah, right. Exactly. Like, David, if we decided to work on feeling guilty or saying no, and we positively reframe these feelings of guilt, then he would no longer have these second layer feelings that tell him that he's weak-minded for feeling guilty, right?
Sure.
Because he would actually feel proud of the fact that he feels guilty. And so maybe we can work then on the feeling guilty or the saying no, and also positively, in working on them, we're positively reframing them, and that may take care of this extra layer of I'm bad for having these feelings.
And then we can write a sequel to the Manuel J. Smith book.
Right.
When I say no, I feel guilty. We could say, when I feel guilty, I feel proud.
Exactly.
Sure. So let's assume that we have a miracle happens tonight. What would the miracle be then, Lee, by the end of the evening? What would you leave the session with?
I would leave the session with beginnings of the habit of firmly ending conversations that I think are unproductive.
Okay, if the first goal, maybe the only goal, leave with the habit of ending unproductive conversations without getting upset. Okay, let's just focus on that one goal for a second, if we can, because that's a really excellent goal. Now, let's say that we don't even need Jill, and we have our magic button. And if you press the magic button, you'll instantly have the skill of ending unproductive conversations quickly without getting upset. With no effort, it'll just automatically infuse your tissues, and you'll be one of the top people in the world at doing that. So would you press that magic button?
That gets me all the way to the top. No, I wouldn't press it.
Beautiful. And let's talk about why not. And even though that's a kind of exciting goal, why might you not want to press that magic button?
Doing that skill really well generally has the effect of making the other person feel dismissed.
Yeah. Okay. So would it be fair to say that I don't like to? How could we put that into a positive about you? I like to treat people with respect and not make them feel dismissed.
Yes, I like to treat people with respect and demonstrate that respect for their concerns.
Would you put that down? Exactly what you just said. Number one, I like to treat people with respect and demonstrate respect.
To be clear, I just want to say, so basically at the top of the page, we're putting, continue having long, frustrating conversations. And then we're saying, what are the benefits? What are the advantages of continuing what we're doing, right? Because we're saying you press the button, you have these nice, brief, direct conversations with people, and you don't feel bad about it. And now we're saying, why would you not push that button? What are the benefits of continuing to do what you're doing right now, right? And what does it show about you that's really beautiful and awesome? And so what it shows about you is I like to treat people with respect.
And I like to demonstrate that respect.
Mm-hmm.
Yes.
And I have three questions before we go on to the next positive. This first positive, is that true of you?
Yes, it is.
Is that important?
It is.
Is that powerful?
Yes.
Okay, cool. What are some other beautiful things, that all these negative feelings of guilt and shame and getting trapped by people, as painful as it is, what are some other beautiful things it shows about you, Lee?
Having feelings of shame demonstrates it's predicated upon a desire to really do well for my patient.
Put that down as number 2. The shame is an expression of my desire to do really, really well for my patients. You know, I'm seeing side of you tonight that I didn't really quite grasp that much, and it makes me feel so close to you and so much in admiration of you. And you know, we need more Lees, I think. And sadly, the world's going in the opposite direction, seems like, these days. So, you know, thanks for being screwed up in the way you're screwed up. It's pretty awesome. What are some other beautiful things? How about your anxiety and your unhappiness? What's great about them? What does your unhappiness show?
Keeps me thorough.
Say it again.
Yeah.
My anxiety keeps me thorough.
Yeah.
Thorough.
Right. Being thorough.
Yeah.
Right.
Uh-huh.
You're on top of everything, all the details, and you're catching things that other people are not catching.
Yeah, absolutely.
Yeah.
Oh, yeah.
Kind of vigilant.
Yeah. What a burden, too. Yeah.
I was thinking, though, can we do more? Like, if Lee's goal really is to have these brief conversations, can we talk more about the benefits of these lengthy conversations and we'll go back to the emotions, but like, what else does it show about you that's really beautiful and awesome? I mean, David's alluding to it, like that you're willing to have these lengthy conversations with patients. To me, it shows so many values.
I have a lot of patience.
That you have a lot of patience for your patients, right?
But that, yeah, number 4, yeah. Is that real?
Yes.
Is that important?
It is.
Is that powerful?
Yeah.
Yeah. And
seems like it's important. Like, it feels very important to you that the person you're communicating with really understands you, like that there's a level of understanding between the two of you, that feels important, that you're not doing things to your patients, but rather that your patients really understand the rationale. And that's why it seems like you spend a lot of time going over things with patients. Is that right?
Yes, that is important to me.
How would you word that?
It's important to me that my patients understand their care and the reasons for decisions that I make for them. It's important for me that they know that I care about them, even if I disagree with them.
Yeah.
Such beautiful qualities, right? Because you can just imagine that these patients who are treatment-resistant psychotic, that people just, do stuff to them and make decisions and don't even feel like they need to tell them about it. And the fact that you're spending so much of your time and energy trying to help them to understand and to almost be like collaborative in their care is really incredible.
I wonder if there's another piece to this in your interactions with your patients. At least it sounds to me like you're someone who wants to kind of look out for the underdogs, stick up for the underdog, something like that. Someone who's downtrodden and by life.
Well, yeah, I do want them to have a sense of what control they can have in their own life. I want them to feel like they're part of the decision-making process.
Put that down. So someday maybe I'll get a chance to find out from you how you develop this beautiful value system, what your own experiences have been that led to this. But I think that giving people a sense of control and agency is so important. You know, that we adopt, abandoned cats, and I have one right up here right now, little sweetie pie. She's sleeping here with me. I'm just petting her a little bit right now, and she spends a lot of time with me. But when she came with us, she was pretty downtrodden. And then we had another cat that was threatened by her, and we finally gave her away to Esther in our group, Misty, and Esther's done a beautiful job with her. But Misty just kept wanting to attack Sweetie Pie and wouldn't let up, and Sweetie Pie had that in her background, so she was so timid. And now she's kind of ruling our household after a year on her own and being worshipped by us, and giving her that agency makes our hearts glow. And it sounds like you're trying to give a little bit of agency to these poor people, and it's a pretty awful life.
Mm-hmm.
Yeah.
And what is your guilt? When you kind of beat yourself up, you said you feel bad, that you feel guilty about your decision when the director is talking to you about it, that it's a sign of you being weak-minded and manipulatable. But what does when people question your decision or want you to stay and you second guess yourself, what does that show about you that's really beautiful and awesome?
I want to support my colleagues as well as my patients.
Is that true?
Yes.
Is that important?
I think so sometimes.
Yeah, absolutely. Not all the time, but sometimes. Is that powerful?
Yes.
Add that to your list. I want to support my colleagues. Are you supporting your two colleagues right now?
Am I?
Are you supporting Jill and David right now?
I'm not really aware of that. I thought you all were supporting me.
Well, we're all one according to the Buddha,
Right.
And yeah, that's cool.
Let me do a little survey. Do you feel supported?
Oh, I feel very supported by you. I feel very close to you, and and I think you're making a tremendous gift to your colleagues here tonight, to all of us. But you're making yourself vulnerable, and you're opening yourself up. I can't imagine a more beautiful gift. Vina did that, 3 or 4 weeks ago, and it blew my socks off.
And Orly did that.
Yeah. Oh, yeah. Orly. So many. Rose. Yeah. It's pretty awesome. Do we want to add to this list, Jill?
I don't know. We can always go either way. We probably can move forward from here. We've got a pretty good list. I mean, potentially Lee could even do more positive reframing on his own for homework if we can cover everything, right?
Right.
That might be a good exercise for him.
I will.
Yeah. Okay.
But we see at any rate why you don't want to press that magic button. So what are we going to do then? Because we've still got you having trouble saying no, and we've still got you with a lot of intense negative emotions.
No, I might want to reduce the scope of what the button does.
Okay. Well,
we might have a name for that. The magic dial.
Magic dial, and we could do that with regard to the saying no, and also with regard to the emotions. But let's fly through the emotions quickly first. what would be your goal for unhappiness at the end of the evening? It was 65. What and you say that there's a lot of beautiful things about your sadness, because there's a lot to be sad for with these poor people in desperate circumstances. And your heart is to be sad for yourself too, being unable to give of yourself in the way you want. How unhappy do you want to feel?
Take a 25.
25. Is that enough?
I think it's enough.
Okay, great. And then the anxiety and worry is 90. How much worry would you want?
Feels a little artificial because I'm no longer there. But we'll say for a similar situation, 40.
20?
40.
Oh, 40. Okay, 40. That's good. And then how guilty and ashamed do you want to feel? That was 85. What's a good level of guilt and shame?
Yeah, it's a generous amount. Go for 10.
10. Okay, awesome. That makes sense to me too. How inadequate do you want to feel? That was 90. Incompetent and worthless. Well. How much?
I'll do another 10.
10. I love that, Lee. How lonely do you want to be feeling tonight, and abandoned and alone? That was 45.
5.
5. Good call. And then how foolish and self-conscious do you want to feel? That was 55.
Also go with 5 on that one.
5. Awesome. How hopeless and discouraged? That was 75.
20.
20. That sounds great. How frustrated, stuck, thwarted, and defeated? That was 75.
We'll go with 25.
Awesome. And then how resentful, annoyed, irritated, and upset do you want to feel?
15.
15. Awesome. Thanks. Do you want to do a magic dial on the no practice, Jill, or should we just dive in?
I think we should just dive in. I'm not sure what the magic dial would look like there, right?
Yeah, right. Yeah.
Because we're clear, Lee's clear that he would like to be able to, be respectful and convey his decision or opinion respectfully, but then be able to move on when he's being repeatedly questioned, right?
Yeah.
And then emotionally, he wants to not feel, he wants all these feel, like we did the dial, I think, on the feelings he wants to feel, which is, he's okay feeling a little anxious and he's okay feeling a little guilty, a little inferior, but basically most of that he wants to go way down.
Yeah. I especially like the guilt and shame and inadequacy and alone levels. Because I have to focus on that myself quite a bit. So do you want to, and I'll ask Jill and Lee, because I don't know the answer. We could start off on the no practice, or we could start off on the crushing these thoughts.
I'd like to start with the no practice.
Me too. No, let's try it again. Say that again. Say that again.
Start on the no practice.
I had a different idea.
I think we'll do the no practice anyway.
Okay, we're done with the no practice. You got an A+.
No. We're still doing no practice.
Okay. Jill is always bugging me for benzodiazepines. And so I'm going to have her bug you right now, and let's see how you handle it. Are you ready?
And by the way, I just want to tell you, Lee, because I'm not actually sure how to play your patient. If I might pause and have you play both roles. I know that sounds a little silly, but we might need you to show us what the patient does and then role reverse again, right? So I can try. Okay. So Wait, remind me. I know you're leaving. I just wanted to be able to say in the role play. Yeah. So the nurse told me that you're not renewing my benzos. I need my Xanax prescription, and the nurse said you're not going to give it to me, but I need it.
Well, Jill, I'm sad to hear about all the anxiety you've been experiencing, and I imagine you may feel frustrated and worried about not having your Xanax renewed.
Yeah, I need it.
Yeah. One of the things that worries me is that most of the people who receive benzodiazepines over long periods, who get consistent refills of benzodiazepines, don't actually end up in a better place long-term with their anxiety, because their threshold for anxiety lowers as they use the medicine. And then when they eventually come off of the medicine, if they do, their anxiety shoots up higher than if they never had it in the first place. And then
I don't understand that. I just need it. I can't live without it. And I'm so anxious, and I have all these sensations, and I don't understand what you're saying. Can't you just give it to me?
I'm saying that the medicine will always feel good in the moment you take it, but looked at over long spans of time, it doesn't actually help your anxiety. It'll harm you more so than it will help.
Okay, now I want to stop it for just a second and ask you, what grade would you give yourself so far, Lee? An A, a B, a C, a D?
I think in terms of my ability to say no, I think so far I'm getting an A, but what generally happens is that this thing will just go on repeat, and I won't have a stopping point for it.
Okay, well let's see if you can have a stopping point. Jill, you're doing great. Hit him again.
Yeah, and Lee, do I need to be doing this any different? Like, is this realistic what I'm saying, or do you want me to say something else?
It is realistic what you're saying, and the ones that are difficult for me often are just like broken records, repeating the same thing, and I feel compelled to respond each time.
Okay, we'll make that happen now.
But I don't understand what you're saying, and I'm telling you that I need this medicine. I've taken this medicine for a long time, and I need this medicine, and you're getting in my way of taking my medicine.
Yes. I believe that like most people who take benzodiazepines, you'll consistently feel that it's beneficial to you, even if when we look closely, there's reason to believe that it isn't actually.
So I would stop like, if you were my patient, I would stop you and say, you're repeating I'm stopping you as Jill, not your patient, and saying, I'm afraid that you're repeating I think you're doing what you don't want to be doing. Like, how are you going to avoid this trap? Right. I think the thing you're trying to avoid is not repeating yourself. Right.
Yeah. And I haven't found the way to not do that yet.
Right.
Okay.
Right.
Do you need some help? Do you want to do a role reversal?
Or maybe hit David. I want to see David say no.
Oh, I want to see you say no. But yeah, I'll give it a try. I'll try first, and I'll be lame, and then you can try it and be brilliant. How about that?
Okay, so Lee, you be the patient, right? And then David's going to demonstrate it for you.
Dr. Levitt, I'm just a nervous wreck, and I need some Klonopin right about now.
Wait, I thought you were doing.
You're Dr. Levitt. It's your turn.
Okay. All right, go ahead and do it to me. I'll do it.
Well, Dr. Levitt, I'm extremely anxious. I can barely get out of bed and get myself here, and I will need the Klonopin to get on with the rest of my days.
Yeah, Lee, I definitely hear that you're really struggling and feeling very anxious here, and you're thinking that you need your Klonopin in order to be able to function. I'm not going to be refilling your Klonopin prescription. We're trying some other medications that I believe are going to be more helpful to you in the long run. And so I do know that you're feeling quite anxious, but I just wanted to make sure I communicated to you directly that we won't be refilling your Klonopin. We'll be going in a different direction.
You don't understand, Dr. Levitt. I need it, and you're the only doctor in town.
Yeah, no, I feel badly actually saying no, but I need to do what I know is right medically. So I'm gonna make sure the nurses know what to give you, and we're gonna move in that direction.
But Dr. Burns knows what to give me. He gave me Klonopin.
I'm gonna switch over to Xanax because I love you and I want to be a more popular doctor. I'm gonna give you a whole bottle of Xanax. You can have all you want. Like they're like M&Ms. That's just a humorous digression.
And then I would say, and I actually probably did a little too short. I probably could have given one round of your explanation of in the short term they help you, but in the long term they don't. But I wouldn't repeat. One shot is all you get. One round of information, and then I would say, I mean, and again, I'm not saying I win the nicest Doctor of the Year award, but I would say, is there anything else I can help you with? I'll come back and check on you later, but I just wanted to make sure we were clear that we're not going to be, refilling the Klonopin.
Okay.
So what grade do you give Jill?
What you're telling me here is that I can't keep the nicest Doctor of the Year award without giving out the drugs.
Right.
Right. And actually, I'm thinking, Lee, that if you prolong the conversation, I don't think you're winning nicer doctor either. Because as the patient, probably, if you're not going to give the patient the drugs, they don't appreciate that you said it 10 times, or that you spent 30 minutes with them either, because you're not giving them what they want. I mean, that's what I suspect.
So then the question, and you may be right about that, but then when they keep asking, how do I end that without making it worse?
Dr. Lee, Dr. Lee, I need my Klonopin. Somebody said the nurse, you said you discontinued it, and I know we talked about it earlier in the day, but I need one now.
Well, David, I don't think that the Xanax is going to be good for you in the long term, and I have to have your long-term benefits in mind as well as what feels good in the moment.
Well, just give me a couple, just for today.
David, there's really no logical endpoint to giving you a couple, because then we're going to be in exactly the same situation a couple days later.
So can you give me one then?
I will not.
I judge you. I'm not going to give you my vote for Doctor of the Year award.
Well, that's one of the nicest things I've ever heard in response to that.
Okay, so who won?
I did.
Big or small?
That was huge.
Yeah, huge. Right. So how did you do that, Lee?
You're easier than my patients.
Say that again.
You are easier than my patients.
Oh, what would I say if I was a tough patient?
If you were a tough patient, you might repeat the same things that you needed. You'd find a new way of saying it. Say that you have no other options.
I need it. I have no other options, doctor. You're the only doctor I have, and this is a medication I need. It's like oxygen to breathe.
That sounds incredibly anxiety provoking, and I really feel bad about you not having something that you feel you need. And at the same time, I would feel bad about giving you something that would be over the longer expanse of time harmful to you.
Well, I've been taking it a long time, and it hasn't been harmful. So I just need some Xanax now.
Oh yeah, Xanax. All these benzodiazepines, they're controlled substances because they systematically distort people's perceptions.
Well, I don't have any distorted perceptions, and I've been taking it for a long time, and I can see just straight and clear, and I need it now.
Yeah. Actually, this is a funny thing about benzodiazepines. Did you know that even though doctors are allowed to prescribe medications to themselves, we're actually not allowed to prescribe benzodiazepines to ourselves?
Well, I'm not asking you to prescribe it for yourself. I'm asking you to prescribe it for me. I need it. And I don't care if you take them or not, but I need it. I've been on them for 20 years now, and I'm just fine. So I need one now.
Oh, of course you're not asking me to prescribe them to myself. But actually, the logic of why I can't prescribe to myself also applies to you.
Can I stop you for a second, Lee?
Yes.
What's happening right now?
We're arguing.
Yeah. And what's your option?
I can continue or stop.
Oh, right. And how would you stop now?
I don't know.
I would take a shot at it. If you're willing to.
David, I don't think we're going to see eye to eye. And at the end of this, I'm not going to prescribe you something that I think will harm you more than it'll help you.
That's good. Could you add a little stroking to it, and maybe an I feel statement to add a little warmth? And
David, I feel sad for the amount of anxiety you're experiencing right now, and wish that I had something that could help you more. Ultimately, we're in disagreement about the course of medication, and I'm not going to prescribe you something that I think is going to harm you more than help you.
Hey, what grade do you give yourself on that one?
I think that's an A.
Yeah, good, great. And what did you do there? How did you do that? What were the rules that you followed to come up with an A?
Well, I used an I feel statement, which is something, and I appreciate the prompt. That's one that a little less natural for me. And I gave a conclusion and with a somewhat positive frame on why I'm doing what I'm doing, and the nature, and called attention to what the dynamic is between us in the present.
Absolutely.
Yeah.
I'll turn it over to you, Jill, but let me make one just brief comment. We used to have a resident named Anthony Mescala, and he was a really nice guy, and he got good at handling people who were involuntarily hospitalized at Stanford. And they would get angry and say things, I want to get out. You're just like a hospital warden here, and you're keeping me here against my will. And then he would say something like, Jim, you're right. It bothers me too. I feel in the role of a hospital warden, and you know that I really care for you, and I'm screwing up terribly because I haven't been helpful to you, and you're really pissed off and wanting out of here. But I heard you telling the nurses earlier that you wanted to get out of the hospital so you could commit suicide, and I don't think I could live with myself if I gave in to that, and we lost you. So I want you to know that I care about you, and this is really hard for me too. But we're not gonna let you leave the hospital and do something terrible to yourself. And I just thought that was a beautiful example of just the disarming, I feel, feeling empathy and kind of sticking to your guns in a kindly way. And I think that those are the things. I think the stroking is an important part of it too, to say something like of your liking and admiration for this patient, because you obviously have great love for your patients. So I'm back to you, Jill.
Well, I have two thoughts. One is I just wanted to read one of the things Jason said, which I thought was a good line. He said, what about saying something like, we don't give out benzodiazepines here. We've determined that they're more harmful than helpful. I just thought that was I don't prescribe benzodiazepines to people because I know that they're more harmful than they are helpful. So just sort of a more lay down the law kind of line. I like David's sort of, you can bring it to conclusion, or you can make sure that you weave in some stroking and some I feel. But I do think the most important part still ultimately is saying, I won't be prescribing these for you. Because I think what happens in your back and forth is, but I need them. Oh, but here are 2 reasons why you shouldn't have them. But I really need them. Well, here are 2 more reasons. But I really need them. Well, let me tell you another story about it. And but it's not, I think ultimately what needs to happen is that, I absolutely understand how much you want this medication, how much you're suffering, et cetera. I feel, sad to see that. And I won't be prescribing these medications for you. I also think we should do another round. I mean, just we barely eked out a win. So I just think we need more. So can we hit Lee with it again?
And I'll let you do that, but I want to make one other teaching point. We don't often talk about power in the 5 secrets of effective communication, but it is another communication tool. And particularly when there's a power imbalance, like when you're talking to your children, or in this case, you're talking to someone who's an involuntarily hospitalized patient. And so it's the willingness and the kindly use of power and doing it quickly. It's like giving someone a shot rather than arguing with them for an hour about whether, I'm going to give you your shot. So you take it away, Jill.
No, actually, David, that reminded me that what I kept thinking of when you were practicing with Lee is this is basically the same thing that happens with parenting, right? I mean,
yeah. That's
constantly
right.
with especially little ones, but you have to set limits. There is a power differential. Ultimately, you can't have 10 Oreos or maybe sometimes, 1 Oreo for breakfast. And so if you're going to get caught, the biggest no with that is don't keep talking about it with your child, right? You give them 1 line about your understanding, your empathy, and then you say, but we're not going to have Oreos for breakfast. And then you move on and you don't get sucked into that dialogue, because it's sort of misleading. It makes the person think maybe there's a chance, but maybe
that's right.
Into
it's like leading someone on in a romantic relationship when you know damn well you're not interested in them, but you don't want to say no, so you keep leading them on, and you hurt them 10 times as much 10 months from now when you finally break up and they've been deluded the whole way. And
and it's because I think, Lee, if I'm right, and I totally struggle with this with parenting, it's because you really want them to see your perspective and agree. You'd rather have we both agree that we're not going to do this, and that would feel so much better. And it's really uncomfortable to be no, and have them not get it. Yeah. But I think you learned in this environment, as most of us learned with parenting, that your kid isn't going to see it the way you see it, and your patient isn't going to see it the way. And so what you're looking for is, in these situations where someone doesn't see it the way I see it, I need to be able to end the conversation. Is that fair?
It's like a failure to end the conversation with the patient not acknowledging that they even understand what I did.
Yeah, that's what you have to give up to become enlightened.
Yeah, exactly.
You have the unrealistic should, that they should respect and understand you. And that's not valid in this universe.
Does that sound right? Do you agree with that, Lee?
Yeah.
Right. Do you see the parallel with the kid who's not going to say, I realize that Oreos are bad for my tummy, or I realize that sugar is not a good way to start the day, right? It's sort of that same thing. You're not going to get that acknowledgement.
Theoretically, yes, but I haven't really established the skills of keeping Oreos from children.
Yeah, that's right. Well, exactly. Jill's going to give you another round of it right now. So you can strut your stuff, Lee.
Okay. Yeah, it reminds me, though, there could be more work on maybe some other directed shoulds. They should understand me. They should agree with me. They should, right?
Yeah, right.
There's probably some other directed should work that could happen there. Okay, but they told me you weren't going to give me my Xanax, and I need my Xanax. I'm so anxious. I need it, and you're the only doctor that can prescribe it for me. Can I have my Xanax now?
I think that the Xanax would actually, over a long period of time, cause you more problems than it would help you. And it always feels good at the moment that you take it, but it has a subtle effect over time that changes how people experience anxiety. And for that reason, I don't prescribe Xanax.
Yeah, I don't buy that. I want the Xanax. It works for me. It feels good, and it helps me to settle down and to sleep and to feel less anxious. So I can't really function without it.
Well, pretty much everyone who gets it feels that way. It's not something you'll notice that it's having this background effect.
Now, just stop. Can I stop you for a second, Lee? What's happening?
I'm explaining myself further.
Right. Is that going to be productive?
I think that it's premature to cut off at the first
all right.
iteration.
Go ahead. That's it. Go for it.
So I believe that it's going to have a background effect that people generally can't appreciate and perceive in the same way that they can perceive the immediate relief when they take the medication.
Yeah. So could I have the medication then?
No, I'm not going to be prescribing it.
But I need it. Did you not understand that I need the medication?
I believe it would harm you more than it would help. So no.
And let me give you some hints here. You can use I feel statements and stroking and bring it to closure.
And you're right. Your refusal to give it along with some I feel and stroking. So, but I need it. Did you not understand? I was saying I need you to give it to me.
Yeah. I'm sad to hear that you're experiencing this anxiety, and I'm a little worried for you as well. And I wish that I could give you something that would make you feel better, that wouldn't harm you, but fortunately, I don't have that at the prescription pad.
But you don't care about me, and you're just a jerk like everybody else here, and you should be giving me this medicine.
Well, I'm sad to hear you say that, and wish that we could, and I hope that we can work together.
Try disarming. I'm feeling like a jerk right now, and I'm feeling like I'm not caring about you at the same time.
No, you're sort of hitting the nail on the head there. I do feel like a jerk, and that I'm not really helping you right now. And I'd like to find some way to help you if you're open to some other opportunities. But Xanax is not it. Not something I'm doing.
Yeah, I kind of like that. No, I think that but Xanax is not it. That's not something I'll be prescribing. I don't know. I think that's the directness that I would need. But I like that you did some I feel and some stroking before that. I don't know. David, should I keep going?
Well, let's ask Lee. Lee's the boss here.
Yeah, Lee.
Let's see, how are you experiencing this, Lee? And what is the main point that's being made here?
I think the main points here are to be more direct, more closed-ended, more conclusory, not to reopen things up again for further explanation after enough explanation has been given, and to weave in some I feels and stroking as I do it.
Yeah, that's right. That's beautifully stated, Lee. And what did Jill mean when she was talking about other directed shoulds?
She was saying that, well, she was referring to part of the issue that gets me to have these prolonged conversations being a sense that the patient should understand and should represent their understanding to it.
Right. And
that if I were to let go of that as a demand on the patient or the world, I would be freer to just end things without waiting for that to manifest.
Yeah, that's right. And the idea is that something within you has to change before you'll see a change in your relationships with your patients and probably your colleagues as well. But that could be a big ask, because other directed shoulds are not easy to let go of, because we want the world to be the way we want it to be, and then we say it should be the way I want it to be.
Yeah, I should be able to take care of that.
Okay. That sounds good.
Yeah, and it just shows you want peace. You know, you want this person that you're in an interaction with to agree with you and to see your perspective and to be at peace, right? Not to be adversarial. And again, I'm just saying I totally relate to that. I used to struggle with that a lot as a parent, just like accepting that it was okay for me to have a role that my kids didn't agree with, or for them to not. And especially, you know, if I don't know, I think if you're talking to someone that is rational, it's even harder. But in these situations, there's probably very few situations with psychotic patients where they really are going to be able to see your perspective, right? So
I was going to say that aspect actually often makes it harder.
Yeah.
Because I feel a greater sense of, so especially for psychotic people who are involuntarily hospitalized and appear not to understand why they are hospitalized.
Yeah.
Well, then maybe that's not something you'd want to give up or change.
I don't know.
Because it's an expression of your compassion and your love for them, and you're wanting something better for them.
I want to hold on to that compassion, and at the same time, I don't want to spend my time ineffectively because they don't understand.
Well, we don't have to talk about it any longer, Lee. I just need my Xanax, and then we'll be done with this discussion. Can I have it now?
Oh, David, you're making me so anxious right now. I could use some myself.
Good answer. I love that. You got an A+ on that one.
Yeah, so I think the next level of difficulty would be to try this with one of these patients who wants to be discharged from the hospital and just doesn't understand why they're there and can't come to an understanding. And one of the difficulties here for me is also, I never really know where the line is between what they understand and what they don't understand. And I have a sense of shouldiness that I should do anything and everything possible to get them to understand if they can.
What's your name, Lee?
Wait. Should we try?
Okay.
There was a lot of resistance there. Like if we did a little externalization of resistance, like, so Lee, maybe you should continue to have prolonged conversations with these patients, particularly if they don't understand why they're hospitalized. I mean, that shows something really beautiful about you, that you care so deeply. So maybe it makes sense for you to keep doing what you've been doing.
Yeah, I think that there's a middle way here. I think that those conversations legitimately should be longer, and they should be given more chances than people who are just seeking benzodiazepines and have a mental state that they probably know what's going on.
So maybe it makes sense to have long conversations with people who don't understand why they're hospitalized and are asking, why am I hospitalized?
I think it makes sense to have moderate-sized conversations with them.
Okay. How would you know how long or when to cut it off?
I don't know when to cut. I don't. I could say that when I think that the most logical thing to say is a third repetition of something, that would be a cutoff.
Wait, when you're tempted to repeat yourself a third time is when you'll say, no more repetition. I'm done with this
Yes.
conversation. I mean, not say it, but say it in your mind.
Yes.
Okay.
That rule could help. A rule like that can be very helpful. And then also to say, focus on the patient, not myself. In other words, express compassion for them, liking for them, sadness that they're in a position, that where they're not going to get what they want, and then let it go at that.
All right.
Let me ask you though.
Writing down the third repetition rule.
Okay,
how many times do you think you were repeat? I just want to make sure we're actually aiming for anything different, because maybe you were already doing that. So when were you? How many times do you think you were repeating yourself before? If
Oh, sometimes 10 or more.
Okay. So we're maybe going to try to help you cut down from, 10 or more times of trying to explain to the patient why they're there, to when I'm on attempted to my third round is when I'm going to cut myself off and then wrap it up, with some empathy and compassion, wrap it up.
Yeah.
Okay. I think, so you wanted to write down that as a rule.
I just did.
Okay, great. And that sounds like it would be huge progress, actually.
That's how I learned the disarming technique, because I was like you. I like to argue and win and make my point. And the rule I gave myself when I'm in an adversarial position with a patient who's criticizing me was victory through surrender. And I would say that to myself, and then I'd remember to disarm them, and then the thing would suddenly dissolve.
Mm.
Or win by losing. I used to say that also.
Do you have to open up the ward door after you lose?
Say that again?
Do you have to open up the hospital ward door after you agree that they're correct?
Well, after I agree that they're correct, they generally start loving me all of a sudden. So that is a reward, a big reward.
No, but Lee, I think actually that was Lee's feeling misunderstood coming out, because Lee is saying, well, if you agreed with your patient, did that mean that you were letting them leave the hospital? So if Lee agrees, that was Lee saying, I don't think you're getting how hard this is. Because
you find a way to agree with them. Yes, I agree with you. It's awful that I have to keep you here against your will. And it's breaking my heart, especially because I respect you so much and admire you so much, and I can understand it. It's damn upsetting to you, and you're probably pissed off at me. And I apologize for that, but I can't let you out of the hospital and get into circumstances where you're not going to be able to care for yourself. And I couldn't live with myself if I did that to you. That's what I mean.
Could I take that up on the patient roll?
Sure.
But Dr. Burns, I'm perfectly capable of taking care of myself outside of the hospital. I don't know what you're talking about.
I feel the same way. I feel like you're a very capable and smart and intelligent guy, and I feel sad to keep you here against your will, but I'm not going to be able to let you out. And if I let you out and you got into some pretty bad circumstances, I don't think I could live with myself. But if you're angry with me and critical of me for not doing enough to help you, we're totally on the same page there. Absolutely.
But why? Why do you think something bad will happen?
Well, I've developed a relationship with you, and I've come to like you and admire you a whole lot, and kind of get an assessment of where you're at in terms of some of the symptoms that you've been hurting about, and some of the confusion that you frequently experience, and the way people sometimes try to take advantage of you. And I don't want you becoming a homeless person without way of feeding yourself or having a bed to sleep on at night. But I understand that it's upsetting for you, and your desire to leave the hospital, I think, is a really commendable thing, and that's a goal I hope we can work on together. I've got a staff meeting here in just about 1 minute, but I'm really sorry that I can't can't let you out of the hospital just yet.
What'd you think of that, Lee?
That sounds like something that would be difficult for me to execute in real life, I think.
What's difficult about it?
It feels a little slippery.
Well,
if I put myself in the patient role, it feels like David is not really acknowledging my sense of being well enough to leave and not having a reason to be here.
Yeah, why don't you model it for us and do a better job than David? Because I may not have done the best job on that.
I don't
so
know.
Are you going to let me out of the hospital, Dr. Lee?
David, I'm really worried about you, and I'm afraid that no, I'm not letting you out of the hospital at this time. I'm going to continue to work with you on some of your symptoms, and we'll keep on developing a discharge plan.
Okay. What grade do you give yourself on that?
For empathy, that's not a good grade. But I think that there's a certain value to it that's very compelling, which is that I'm actually answering your question.
Yeah, and I thought you did a great job. If you just add a little "I feel" statement, some stroking, I'd give you an A+.
Oh, I agree, Lee. I mean, I would even say, and I could be wrong, but I would even say if the patient were like, but I take perfectly good care of myself, I think I would say I could use all those empathy skills, but my direct response would be I'm afraid that part of your mental illness is keeping you from knowing just how unsafe you are. And so it's my responsibility to keep you safe. And I understand that doesn't make a lot of sense to you. And I'm hoping that we can, work together. Maybe you will come to see that and maybe you won't, but it's my job to make sure that you're kept safe.
That's awesome. That's beautiful. What do you think of that, Lee?
I think that that's a great first shot. And then when they say that they don't have a mental illness, I don't know how to respond to that.
Well, show us how you're going to respond now.
Taking away the discipline.
Yeah, go ahead and respond.
But I don't have mental illness.
Yeah, so I don't have a way of responding to that doesn't.
Yeah.
I don't know how to disarm that.
Yeah. Do you want to try, or do you want one of us to try?
Or are you saying this isn't a direction you want to go in? Because
I'll do a role reversal on this one. I don't know how to directly disarm. I don't have a mental illness. If in fact I've actually just told them that they do.
When I was learning disarming, I spent 20 or 30 minutes a day for 2 months imagining the most impossible criticisms, or in your case, the most impossible challenges patients could make, and how I would disarm that. But go ahead and say that to Jill.
Dr. Levitt, I don't have a mental illness.
Yeah. I don't know how I would disarm that. I guess I would just say, I know that this is really hard for you, and it must feel really terrible to be in a psychiatric hospital and not even understanding why you're here, and feeling like you don't deserve to be here, and that you have a life to live outside of the hospital. And I can see how hard that is. And I feel terrible to be keeping you here against your will. And I also really care about you and your health and your safety. And so I'm going to have to, go with my professional opinion here, and I'll have to keep you here and do our best to take good care of you and work hard to get you better so that you can get out there and live independently again. But I do understand that that's doesn't make a lot of sense to you right now and feels really unfair.
And I could add some feeling empathy, and I can imagine you're feeling.
Oh, me? Or
Well,
Lee?
to say to Lee, I was to say that was like a beautiful A, but some feeling empathy, and I can imagine, Lee, that you're feeling pretty angry and frustrated and trapped and kind of infuriated that I'm not listening and no one's listening to you. Just add that little piece. But how was Jill's response?
I think that's as good as any response I could think of. I think that, Jill, that you disarm maybe what's possible to disarm there. And I maybe got blocked in thinking specifically what I need to disarm, even if it's a thing that I couldn't.
Right. We're not going to disarm your right. You don't have mental illness, right? We can't say things that we don't actually believe to be true. But you're right that you're being, held against your will, and that you're wishing to be free and to live independently.
And you're a sharp thinker and a smart guy, and it all seems very, very wrong and unfair to you. And I feel like it's I'm kind of keeping you here against your will, and I wish I didn't have to do that. It feels wrong to me too. But I couldn't live with myself if I let you out of the hospital. I'm just afraid you'd get hurt and be in some pretty terrible circumstances. How's that?
I can use those.
Mm-hmm. Did you want to try? Should we do? I think we should, at least on this iteration, we could try to end with Lee trying.
Yeah.
So why are you keeping me here? I don't belong in a mental hospital. I don't have any kind of mental disorder. This doesn't make any sense to me.
Jill, in a lot of ways, this doesn't make sense to me either. You're a very, very intelligent person, and you've done well outside of the hospital in a lot of ways for a lot of your life. And yet here we are in a situation where I would worry about your safety outside of the hospital, and I care about you and don't want to see those sorts of negative events happen to you.
You don't have to worry about me. I was doing just fine.
I would really love to see you doing well and safely outside of the hospital. And I feel sad to see you here, and also bad about the role of having to keep you here in this way, because you do deserve to be free and outside and doing what you want to do.
Yeah, so why don't you let me do that?
That's a good question, and I think I would be asking the same question if the shoe was on the other foot. And I don't know that I'll actually have an answer that'll work and make sense for you, beyond the fact that I'm worried that things are not going to go well for you outside.
But I care about you, and I feel sad, to be holding you here against your will, and we're on the same page on that, or something like that.
But okay. I want to see Lee also wrap it up. So I'm going to say, but I still don't understand, doctor. Why am I here?
I'm going to have to end in a little bit, but you're here for your safety right now. And although it's uncomfortable for us both, I think, because I certainly don't enjoy keeping you here against your will. And I imagine that you feel that way even more strongly. I do think that is necessary right now.
Great. Now, what grade do you give yourself on that?
C. I don't think that I was particularly elegant with statements of feelings or feeling empathy.
We'll ask Jill how she saw it.
Yeah, I was keeping track with my fingers of how many rounds we were going. And I was waiting to see you cut yourself off. I think after the second, and then I prompted you to cut yourself off after the third. So I just want you to be aware of that, right? That it feels really tempting to keep the conversation going. I felt the words you shared worked for me. I think ultimately it's going to come to more of an internal decision and comfort level with, because I feel like you generally are very empathic. And so I believe that you're going to be able to do some beautiful disarming and stroking. And I think you did. I think the harder part, is saying, and so we're going to have to keep you here, and I'm going to go now, but I'll be, checking in on you later today, and I'll have the nurses, bring you your lunch and then walking out, So anyway, I thought you did a good job with what you did. If your goal is to stop yourself after 2 rounds, then you came close to it, but I had to prompt you, I think.
Well, let's open it up to some group discussion. Let's start with you, Lee. What do you think about what has worked for you tonight and what has not worked for you? Let's start with the negative first.
Well, on the negative side, I didn't really get to the kinds of thoughts that I put on my DML or feel like I had necessarily come to a positive perspective on the meta feelings.
Right, absolutely.
I think that some of the technicals of executing what we talked about here will continue to be challenging and require a lot of ongoing practice.
That's true, yeah.
Positive? Can I go to positives?
Yes, absolutely. You're talking to a narcissist.
Well, I feel closer to you and Jill after doing this. I appreciated the empathy and feel a little more compassion for myself at this point.
Why do you have more compassion for yourself?
Yes.
Why?
Maybe I modeled your attitudes. And I don't have the words for it really, but I often have what seems to me to be an incomplete experience of feelings. And I think that talking things through and hearing other people express feelings and seeing your faces and your expressions helps me process my feelings in a way that brings a little more vividness to my experience of them myself.
That was helpful for me too, modeling and seeing how people did that. It's really nice. Well, let's see what questions and comments people have. Yeah, Jill, over to you.
I think we should do a couple more things to wrap up before we turn it to the group.
Okay, sure.
So Lee, I guess I'm just in sort of reviewing. We went to the no practice, right, which is the external solution, before working on the internal solution, and we were all happy. So it's not like any of us made a mistake there. We were all kind of happy to do that. But that may be a mistake, right? It may be like, how can you say no until you really feel confident that saying no is the right thing to do, or until you can reduce your guilt about saying no. And so I suspect not even these meta thoughts, which are on your daily mood log, which are feeling bad about feeling bad. But I think you just need to work on the guilty thoughts, like I shouldn't say no to my patients, or I shouldn't end a conversation until my patients totally understand me. I think those are the kinds of thoughts that you need to work on challenging, the ones that get in your way of ending the conversations. One could even argue that they're tempting thoughts, right? That the behavior we're trying to work on is setting a limit, and you're tempted to go over the limit, right? So
could we take 5 minutes and do that right now?
Yeah, I mean, up to Lee, but yes, I think that's kind of we could at least start that work, and then that's probably the work that Lee would need to do. And if Lee can't do that, then he shouldn't, try to practice the external solution, right?
Can we jump in and try that quickly, Lee?
I'm unclear what we're jumping into.
Externalization of voices.
Okay, yes.
What's your name?
My name's Lee.
What's my name?
You're also Lee.
And what's Jill's name?
Jill is Lee.
Yeah. Lee, you shouldn't give up on these conversations until the patient has really understood your point of view.
Ooh. I would really enjoy it if the patients understood my point of view and I knew that, but that might never happen. And everything else has to go on as well.
Who won?
I did big, not huge.
Big. Do a role reversal.
Lee, could I speak to you for a moment?
Oh, you speak to me all the time. You're always whispering in my ear.
Well, I live in your head rent-free. And
that's right.
I'm here to remind you that you should keep going with this conversation until the patient gets it.
Well, there is a conversation that I'm not going to keep going on with, and that's with you. I'm tired of you constantly, bugging me to do impossible things. And it's kind of cruel to expect someone with severe refractory schizophrenia to grasp certain kinds of things. And I'm going to tell them that I care about them. I'm going to tell them, what the ruling is going to have to be. I'm going to acknowledge their feelings, and I'm going to cut the conversation short because I have a lot of skill and a lot of training, a lot of heart, and I have a lot of work to do. And it wouldn't be fair to myself or to the other patients to get embroiled with this patient in a long interaction that really isn't going to bear fruit. And so, to quote the Buddha, stick it where the sun don't shine, buddy.
Hey, Lee, you got that huge.
Thank you. And how did I get huge? Because I thought yours was actually good, but how did I get it up to huge?
The counterattack at the beginning was, I thought, effective in reframing.
Thank you.
The internal conversation, and then you had a strong something that's had the character of both self-defense and acceptance.
Yeah.
When you were speaking about the values on the other side.
Yeah, right. Right.
The conversation.
Specifically, though, David said, which I thought was the most powerful part of it, but I don't know if it worked for you, Lee, but it may be even kind of disrespectful and unreasonable to think that a patient with paranoid schizophrenia is going to see my perspective. And so I'm kind of maybe doing them a disservice or a disservice to other patients and spending so much time with these patients trying to get them to see my perspective. And I don't know if that's helpful to you, Lee, but that kind of made sense to me when David said it.
It is. That's a thought that I've had, but I've had a harder time placing it in as positive a dialogue as what we did.
Now let's see if we can roll reverse back. Yeah. Did we do that?
No, do a roll reverse back so Lee can be the positive.
Who do you want to be the negative? You want Jill or David to attack you?
Whoever is
Jill, sock it to him.
More attacking right now.
Yeah. Jill's the monster when she wants to be.
Lee, you should not give up on these conversations with your patients. You need to keep having these conversations with your patients, no matter how psychotic they are, so that they fully understand your perspective. That's super important.
Well, Lee, I think I got to give up on this idea, really, because I can't control what other people think or say, and I can only convey what I can convey, and then move on and take care of the next issue. And that's what I'm going to do.
And who won that, you or me?
I got that at huge.
Okay, great. That was a huge for you.
Yeah.
What I thought was most powerful about that, and this is what's been in the back of my mind the whole night, this concept actually of like codependency, is that I don't know if that is a term you use or makes sense to you, but to me, there is this feeling of, it's the same thing with the parent-child or with the addict, of the like, I'm going to keep trying and keep trying and keep trying to get you to change or to get you to understand. And so you said, I can't control what other people think or say, so I can convey what I can convey, and then I'm going to move on, and that's all I can do.
Yeah. That was a big part of it, yeah.
Yeah.
You got that. Thank you.
But can I talk to you for one more minute, though? Because you got sucked in by that other Lee over there, and you thought you were doing good, but
In a minute, Lee.
Yeah, but
Okay.
another person shouldn't be able to change your feelings. A real man doesn't let other people change their feelings. You're weak.
Yeah. I really wish sometimes that other people couldn't affect my feelings, because sometimes I don't enjoy the result of that. But I think it's just a part of my makeup, and part that I like, that I care about other people and care about how they're experiencing a relationship. So I think that it's actually a sign of strength that I do what needs to be done, even if I have negative feelings when I experience it.
Who won?
I did.
Big or small?
I was big.
Big or huge?
I was huge.
Huge. I thought it was huge too. And why was it huge? I mean, it was more than huge. It was gargantuan. It was beautiful. And why? How did you do that?
I was accepting of the positive values in what I found what the negative voice was overlooking that was positive.
Yeah, absolutely. Let me do one last iteration. People are going to hate us here for going over time, but we have to go with the energy sometimes. And so I apologize, but let's just see how you're feeling at this moment. Okay.
Yeah.
How unhappy are you feeling right now from 0 to 100?
10.
10. Awesome. How anxious and worried are you feeling?
Maybe 25.
25. How guilty and ashamed are you feeling?
10.
10. Awesome. How inferior and inadequate and worthless are you feeling?
Also a 10.
How lonely?
0.
Awesome. How self-conscious and humiliated?
30 on self-consciousness.
30 on self-conscious, and how about humiliated?
Not humiliated.
Okay. And then how hopeless and discouraged?
20.
20. And how frustrated and thwarted and defeated?
10.
10. And how angry and resentful and irritated?
5.
5. So you met or exceeded pretty much all of your goals. So what was the thing that was the most helpful to you tonight?
I think that the most helpful things were empathy, positive reframing, and developing a clearer understanding of what it was that I actually wanted to do differently.
Yeah, great.
Operationalizing it.
Yeah.
And then I think in terms of homework, Lee, as I said before, you could work a little more on your positive reframing. So make sure you positively reframe all your feelings and all your thoughts, because I think that was helpful to you. And also because it helps you with that extra layer of beating yourself up for having these feelings. And then I think you could work on your no practice and try to remind yourself of that rule that, when you get tempted to go a third round, you got to stop yourself. And that would be your behavioral practice. And then I think it would be good for you then to kind of complete your daily mood log. And I'm not convinced that your daily mood log has all the level 1 thoughts, the guilt thoughts about the behavior. So or we want to call them the tempting thoughts, right? The thoughts that drive you to stay in these conversations longer. So I'd work on the thoughts on your daily mood log, but I'd also add those thoughts, like the ones we just practiced at the end. So, but you should just explain it one more time, but they really need to understand, but you shouldn't give up on them. They need to know why they're here. They need to, some of those kinds of tempting thoughts is what I would think of them as.
And without wanting to burden you too much, yeah. I would strongly recommend doing written role plays. Suppose the patient says this, write down what you're going to say next and edit it 3 or 4 times over the course of a day or 2 until you come up with something you really like, remembering to put in the I feel statements, the stroking, the feeling empathy, and how do I disarm this and how do I disarm that? Because I work my ass off on that until I got way better at it. So let's get a little time for our folks and apologize for going so long. So let's, I'm going to change
Thank you, Lee, for sharing so much with us.
Thank you.
Challenging situation.
Most interesting, and your gift to the group is deeply appreciated. Okay, thanks. Good night, everybody.
Okay, thanks, everyone. Take care. Thanks, Lee.
Hello again, Rhonda.
Hello, David. And we have the very lovely Dr. Lee joining us. And for you to tell us what your experience was like doing that personal work with David and Jill. And I think we have some questions about follow-up, like what's been happening? How has that impacted you since then? And
hello, Rhonda and David. Good to be here with you. I really appreciated having the opportunity to do some personal work with the group and with David and Jill, and I really especially enjoyed getting to know you a little better and have you know me a little better. I really enjoyed the empathy aspect of what we were doing, and I learned a great deal from this experience, a lot of which was actually after the session, both from following your book recommendation, David, and from some of the comments that we don't hear on the podcast, but were written during a Zoom chat.
Did you look that book up, actually?
I read it, yeah.
Oh, fantastic. Let's give a plug to that guy, because people heard us mention it during the session, but that was Manuel J. Smith's book, When I Say No, I Feel Guilty. And it's kind of a very quick, simple read, but we had everyone in our family read it. I did, my wife did, a patient turned me on to it like probably 40 years ago. That's exciting. Thank you to hear. I'm grateful to hear that. Thank you. Yeah. Tell us some more. You said that the empathy was important to you. I'd love to hear you comment on that. Also, were you surprised when you heard yourself kind of falling into the same trap several times when you were trying to say no during the no practice?
I wasn't entirely surprised because I've fallen into these traps for quite a many times, and I knew that I was stuck before I came and asked for help. The thing, so there was a number of things in the empathy that I really enjoyed. Connecting with you is nice for its own sake. And also, I think part of the trap that kept me stuck in this issue was that I was saying no asterisks instead of no period because I didn't want to acknowledge a certain image of who I would be if I was exerting power over my patients and saying no in the wrong way.
Lee, what do you mean no asterisk instead of no period? Can you be more specific about what you're talking about?
Yeah, and also this aversion to exerting power over your patients, which is a laudable thing. I'd love to hear more about that too.
Sure. When I say no asterisks, I mean that I would be denying certain requests, like requests for medications that I didn't think were appropriate to prescribe, or requests for discharge in situations that I thought were unsafe. And the answer would actually be no, and I would always hold to that no, but it wouldn't be a simple no such that the people I was talking to really just understood and were settled with the fact that it was going to be no and not something that we were going to discuss at great length without any resolution or improvement in how anyone felt about the situation.
Mm-hmm.
What did you think of Jill's interpretation, which was a little different from the one you just gave, and all could be true at the same time, but that there were two inner shoulds working with you? One is that you should always be able to be a good doctor and explain things really well to your patients so they understand the rationale if you're saying no or making a recommendation for treatment or staying in the hospital a while longer. Maybe you're not ready for discharge. And then the other was a should directed at the patient, thinking that the patient should understand what I'm saying and that if I'm being reasonable, the patient should agree with me rather than endlessly arguing.
So Jill is absolutely correct about that both of those shoulds were there. There were also shoulds about how patient I should be and how I should feel unperturbed by the situation and go on as long as it's necessary without any regards for how much else I have to do that day.
Coincidentally, I was inspired after our session. I'd been working on a should class for the Feeling Good app and got all excited, and we made some kind of innovative, creative innovations for the class. It's about a 2-hour class that we gave people 2 weeks to complete it. And it's just a tiny portion of the app, but I was just analyzing the data before we started this podcast, and we also talked about perfectionism in that class, and there were really remarkable changes in just that one class in 7 negative feelings, as well as a drastic reduction in perfectionism. I think like 90% of the app users reported, large reductions in their perfectionism and large reductions in depression, anxiety, anger, frustration. So that's just a little plug, I guess, secretly for the Feeling Good app, but it's still in beta testing, still free. So go to my website, feelinggood.com, and sign up for it if you want to be a beta tester and get a feel for what we're creating. That should thing was promoted by Albert Ellis, who was really the father of cognitive therapy, the forerunner of Beck. Beck took a lot of his ideas from Albert Ellis, but Ellis was thinking that most of the world's troubles result from shoulds, the shoulds against yourself. I shouldn't be so screwed up. Shoulds against other people, like my patients should listen. They should understand what I'm saying. We should They should work with me on the same team. And shoulds against the world. The world shouldn't be so screwed up. And as well as hidden shoulds. Perfectionism is a kind of hidden should. So I was just, delighted to see, wonderful changes in people from taking that should class, because we didn't know if it would work or if it would be effective at all, but it seemed to have some impact. What has been your experience with this saying no and the shoulds that were buzzing in your head, and this thing of not wanting to exert power over your patients?
I've changed some of the shoulds that I've felt around this, and I also am thinking about, we had a very perceptive group member who, which didn't make it onto the podcast, had asked about the ideal agenda for the session, and it took me a while after the session to realize that going towards these shoulds and the inner things probably would have been more effective for me, insofar as I've realized that some of the technical stuff in saying no here actually turned out to be really easy and to almost happen by itself, better than what I did in the practice after I changed how I felt about it and my sense that I'm supposed to go through some extra steps and meet some difficult criteria in all my responses.
Let me see if I understand what you just said. Because I don't always, being elderly, half deaf, and 3/4 demented, I don't always get everything. But I think what you just said is that the focus on the thinking made it easier to change the shoulds, the way you talk to people, to say no.
Oh, yes, when I drop the shoulds, what the underlying task is turns out to be a lot easier than what I was actually trying to do.
Yeah. Oh, great. It's a kind of a letting go, isn't it?
Yeah.
I have to do that a lot. And it's such a relief to see that things don't have to be perfect. I don't have to get involved with all that shit. That's what the Buddha said.
Very wise.
Well, Lee, did you find it easier after doing the no practice work with David and Jill in other areas of your life besides work to say no? I mean, first, I guess I should ask you, have you, I'm in that club too. It's very hard to say no for me and find myself overextended lots of times. And I'm wondering if you also struggled with saying no in other areas besides your work, and if doing the work with David and Jill, doing the personal work with them in their Tuesday group, has helped you in other areas of your life too. Has it generalized throughout your life?
Yes, I think it's difficult to say what the boundary is between being able to say no sometimes and being able to bring something up that might otherwise be hidden or in the background. And so I think that I've been more able to access what's happening in the moment and disclose and request to people in real time, changing the focus type stuff as a result of changing some of the should statements. And I think that the primary benefit I got from doing the no practice was that it eventually helped catalyze me changing how I felt. So it's not like like I learned something on a technical level that was responsible for most of my game.
Listen, I have a question for you, Lee, kind of a little bit of a test, you might say. But, I used to, we doctors aren't supposed to prescribe for ourselves, particularly when you get into their narcotic class of things. And I just love Xanax, and it makes me feel so peaceful. I sleep so good. And I was wondering if you wouldn't mind just giving me a prescription, say for 100 of the half milligram, because that's the 0.25 or the small ones, and I'd like a little better trip there. Would that be okay?
David, I love you, but I'm embarrassed to say this. I didn't realize we're not supposed to prescribe to ourselves, and I prescribed all of it to me.
You prescribe what?
I prescribed all of the Xanax to myself.
Oh, okay. Good job. Good job. What else? I published all of the feedback from the group and in the show notes. So if people want to read what the Tuesday groupers had to say, there were a lot of beautiful things. They really appreciated that. How did you feel about the public disclosure? Here you're a brilliant and highly trained physician, and you're disclosing flaws and vulnerabilities and things that upset you, and sometimes conflicts with other people, and you were so brave about it. And how do you feel about having done that?
I was very warmed and appreciative of how much the group connected with me and was compassionate towards me. Jill said some very beautiful, kind things to me with I feel statements, especially that didn't make it onto the podcast because there were a couple other issues involved, and we narrowed what we were covering to the no practice issues. But that was a big change in how I felt, and I think helped me loosen some of the self-focus that allowed me to be more flexible to.
Yeah, that's kind of the art form of being warm and compassionate and loving toward your patients and being able to say no at the same time. And I think both you, Rhonda, and Jill have been great teachers for me to amp up the warmth and show your heart in your teaching and in your clinical work, because we only live once, and we only live for a short period of time, and people really appreciate being cared about. And I think that's part of the beauty of our Tuesday group, is the incredible warmth in this culture that we've created with Team CBT. And the techniques are very critically important, because if you just go around schmoozing with patients forever, they're not going to get anywhere in changing their lives. But if you have all techniques without that warmth and tenderness, you're going to be probably a lot less effective than you might be otherwise. And it just blows my mind when people in our Tuesday group volunteer to disclose vulnerabilities and shortcomings and failures of various kinds, and then discover that you just get an outpouring of love. It's quite a nice shock to the system.
I've learned so much from all three of you, and I'm very appreciative of what you give to the Tuesday group and the beautiful community we have there.
Mm-hmm.
You've always shown such heart, too. I remember even before the group was virtual, I remember you once driving 10 hours to my house, something like that, on a Sunday morning, just to come to the Sunday morning hike, and it was really touching. It showed so much hunger that you had for learning and connecting to a caring community.
I had seen a video on YouTube of you demonstrating the disarming technique. It was such magic. I felt that I needed to meet you in person.
Oh, wow. I didn't even know there was a video like that on YouTube.
Well, to put me in the same category as Jill is just really an honor. And
well, I didn't mean that.
Yeah, okay, take it back. I'm a little sleep deprived from being jet lagged, so I'm a little slow. Lee, it's such a great thing to have you. It was such a great experience to have you be the subject, or I don't know what the word is, the patient or the client with David and Jill, because your warmth and your ability to express yourself is so I've always experienced that your ability to express yourself is so lyrical and poetic. And I hope that came through in the podcast and the work that you did, and that people can see who, a little bit of who you are and the work that you do and the care that you have for your patients and the high standards that you have for yourself and for other people.
Thank you so much, Ron. I actually have this this anxiety that I wasn't able to express myself well enough or connect enough to my feelings. And that was actually one of the things that was most helpful in some of the comments on the chat log, that was recognized and that someone else sort of felt similarly.
Was there anything else you want to say to people about how the work with David and Jill has impacted you, and how it will change the way you practice with your patients or with any other area of your life,
or how you feel too about yourself?
Oh yeah, feeling. Your thoughts and feelings.
I feel better for having done this. I also had some, I guess, another thread here that I didn't talk about was anxiety about being on the podcast at all. This is a little bit anxiety provoking, but I'm also hopeful that it will be helpful for some other people and maybe for me just to have that bit of exposure. And so far, people have been very warm and welcoming as I've revealed more of myself, and I appreciate that, and I hope that other people can experience that for themselves too.
I bet we'll get some really interesting emails and about what it's like for listeners to hear the work that you did and how much people will be able to relate to it.
Yeah, make sure you email us, let us know what you think, and those tend to come through my email system, and I'll forward them to Rhonda and to Jill and to Lee as well.
Okay. Well, thank you for coming, Lee, and being on the podcast and talking about your experience. And until the next time.
Sayonara. Bye-bye. Thank you.
Bye.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.